Hello guys, good evening, good evening. Am I audible? Am I visible? If so, say me a hi and a hello. Good evening all. So today we are going to see about neoplasias. So like I put in the WhatsApp group, I'm going to talk about neoplasia in detail today. So it might be a little bit longer than the usual one shots of mine. So because we have not covered the neoplasia entire lecture batch, I want to take care of entire neoplasia. So these are the overview of what might come in an exam, right? So in an exam, neoplasia is not a unique topic. It is correlated a lot. So if you know the basics here for a second internals, third internals, and for university exam also it helps, right? So the possible essay questions are the molecular hallmarks. By default, molecular hallmarks can come as an essay. They can just ask you like describe all the molecular hallmarks there. They can ask you about the clinical features and diagnosis. They can ask you random cancer, clinical history of breast cancer. How do you approach this case and how do you diagnose them, right? This all can come as an essay. And in short notes, I can have a question on each molecular hallmark, right? Talk about proto-oncogene, talk about tumor suppressor gene, right? How do tumors evade immunity? A very important thing, because tumors evading immunity is a new molecular hallmark, so please do remember that. They can talk about PNS. Can anyone comment what is PNS? PNS stands for paraneoplastic syndrome, right? Perfect. So there is a possibility, very high possibility, talk about paraneoplastic syndrome and give me 5 6 examples of paraneoplastic syndrome. Can come in a short note. Tumor markers, very important, right? How do you diagnose cancers? That also might come in exam. Mets, possibility can be there in both short answer and long answer, because if you look at metastasis now, there'll be initially in the first half of Robbins, it'll be written like, okay, it can go to the lymphatic, it can go into the hematogenous, it can go into the drop metastasis, abdomen, seeding of vertices, everything that can be a 5 mark. And you can also have a question on steps of metastasis, right? Everything can come. And if time permits, we'll also talk about a little bit about viva voce, right? Are you guys ready? So if ready, do comment. If you're not going to comment, I'm not going to take the entire thing, right? If you guys are going to comment, we'll definitely look into the entire neoplasia in one shot. Fine. Ready for it? Perfect. So there are few questions which might not be exactly in the textbook, like compare the benign and malignant conditions. We'll look into that also, right? We'll compare the benign tumors, we'll compare the malignant tumors. What are the difference between benign and malignant tumors? Again, possible a 5 mark or 3 mark question, right? Perfect. So basics are always important. This might be there in your MCQs. This might be coming in your Viva question, right? They might ask you like, when will you call something as a carcinoma? Guys, I want you guys to comment. When do you think when we'll call it a carcinoma? Carcinoma is any malignancy of an epithelial origin, right? If a malignancy is of an epithelial origin, I call it a carcinoma, like squamous cell carcinoma, adenocarcinoma. And the most important thing, the naming of a carcinoma is named based on what? Based on the microscopic appearance or microscopic pattern, right? Guys, I want you guys to interact. It's fine if you make a mistake here. Make a mistake here so that in the main exam you don't make a mistake. Can anyone tell me what is the marker for a carcinoma? Immunohistochemical marker for carcinoma. We did discuss them in the Nischay batch as well, right? Hi Sad Vibes, good evening, right? So tell me the marker, I'll go to the sarcoma. Sarcoma by default is a malignancy. It's a malignancy of an mesenchymal tissue, right? Mesenchymal tissue ka malignancy is sarcoma. Sarcoma, always the naming is based on the cell of origin. Fibrosarcoma, osteosarcoma, leiomyosarcoma, right? Based on the cell of origin. From wherever it comes, I'll have the cell of origin, right? Then immunohistochemistry. Again, come on, there's no takers for immunohistochemistry for carcinoma. I thought you guys know better. Sad vibes, come on, comment. What is the immunohistochemistry for a carcinoma? Every epithelial tumor has something called as keratin, right? Skin has keratin. Skin is an epithelium, right? So the marker for this is cytokeratin. Actually, the last we'll also talk about immunohistochemical marker. That also can come as an approach for short note. We'll compile most of them required from an exam point of view, right? And IHC for a sarcoma is Wyman-10, right? So these both are sensitive markers. These are not specific markers. This is to start with. We'll go to the first long answer, fine? Okay, you guys are very silent. I'll ask you non-academic question, right? At least then that will make you type something and comment something and interact something. Sad Vibes, which college are you from? Whoever is online here, just tell me which college you're from. I did my UG from Kilpauk Medical College and PG from Jibma, right? So you tell me where are you doing your UG? Great, Subhajit. Subhajit started with the academic question, but I also want you guys to comment on many other things, fine? Perfect. Now, let's go into the molecular hallmarks. Molecular hallmarks of neoplasia is something which is very, very, very important. So we read about a story for neoplasia. If you remember the story to remember all the molecular hallmarks was, there's a kid who was keep on growing, right? The kid was the cancer who never required food. There is no need for food. Okay, fine. Hi, busy notes making. Okay, no issues. We'll give you the annotated PDF still, right? But I still want you to listen. If you're making notes, amazing. Hi. But I'd say if you can interact here, listen to it, understand it. Notes will be there in the Telegram channel. You can definitely go and write in the exam hall. Fine. Perfect. The kid requires no food and there is no one to reduce the growth of the kid. Fine. Great, Subhajit. Right? That's second. Next, we had the constipation analogy, where the excretion, the normal physiological process of excretion will be stopped, right? There'll be stopping or reduction in the normal process of excretion or normal process of cell death. That's what we said. And we had a doctor, the Warburg doctor, who called it an metabolic problem. That's the Warburg doctor, right? Great, Tejinder. Next, we had the Ayush. I compared Ayush to my innate immune response. My innate immunity also will fail here. That's my innate immune response failure or evading the immune response, right? Once Ayush went, we had the anti, which who called it a ghost, right? So anti-ghost is your limitless replicative potential. It will divide a lot. Limitless division, limitless replication, that is one, right? Then we have the angry red kid. If you remember the angry red kid, red is for angiogenesis, blood vessel. That's your neoangiogenesis. New blood vessels obviously is required whenever a tumor is going to become bigger and bigger, right? Last but not least, kid moved from its place to a different place. That's the last one, movement or metastasis, right? What we had done in the Nischay batches, we had covered a little bit of them, right? I'll definitely re-go with everything again. I might first take the bigger topics, then go to smaller topics. For example, normal excretion apoptosis, smaller one, right? Angiogenesis, smaller one. Limitless replicative potential, smaller one. But rest of them are bigger ones. Potential for them alone to come as a short note. We'll cover them first, then let's go to it, fine? Kaleem, this might be enough for your prof exam, but I would say if you have a bit of a basics again, that will help you to streamline through, right? So 2.5 hours or 3 hours of lecture might not be, I would say this is not enough because I want you guys to read a lot, right? 3 hours of lecture will help you just to scrape through and pass the exam. If you want to aim a distinction, this is a base, add on more to it, fine? Perfect, let's come back to it. So these are the 8 hallmarks of neoplasia as per the term of Robbins. Self-sufficiency of growth factors. This is nothing but I'm going to talk about your proto-oncogenes. Then insensitive to do growth inhibitory factors. This is nothing but your, I am using the short form tumor suppressor genes, right? Then evasion of apoptosis, the constipated kid. Altered cellular metabolism, here is where the Warburg comes into play. The oncometabolite comes into play, right? We'll read a little bit about Warburg and oncometabolite a little bit later, but we'll go to the bigger ones now, right? Evasion of immune response, we'll read in detail. Limitless replicative potential is very simple. This I'm sure you guys will comment because you know already in your biochemistry. What is the reason for a DNA in a dividing cell to keep on shortening? What do we call that? Anyone? Kaleem, Tajinder, Subhajit, hi. What is that? Every cell division, the DNA keeps on becoming smaller and smaller and smaller. We call that telomere shortening, right? Here, telomere shortening will not happen as simple as that because the enzyme telomerase gets activated. So when it becomes shorter, becomes bigger, becomes shorter, becomes bigger. That's a simple thing about limitless replicative potential, right? So limitless replicative potential is just your telomerase enzyme activation. Yes, Kaleem, it might help. Fine. For telomerase enzyme activation, this is where, because of the enzyme activation, perfect. So whenever it shortens, becomes bigger. Whenever it shortens, it becomes bigger, right? Great. That's what happens here, right? Perfect. Then sustained angiogenesis. Angiogenesis, now I'll cover angiogenesis also in detail, but I am sure that you already know. In the wound healing chapter, we had a growth factor. Can anyone tell me the growth factor which increases the blood supply? The same growth factor is involved here also. I'm just writing it in short. The excess amount of VEGF and the excess amount of FGF beta. More vascular endothelial growth factor it is, more you'll have the angiogenesis. Hi, Max will come back 2 years later. We'll definitely talk about pathology. Fine. That's about neoangiogenesis. Ability to invade and metastasis. Invasion as well as metastasis are hallmarks of a carcinoma. Any cancer, even sarcoma, right? So invasion metastasis, what you have to remember is you'll have to know about the roots of metastasis. When I talk about the roots of metastasis, I'm going to divide them into lymphatic roots, hematogenous root, the main ones, and seeding of body cavities. Okay, I'll tell you the reason why I'm writing here, because this is a template. Before the exam, I cannot go and look at the 3-hour lecture or a 30-page notes. One screenshot is enough for me to recap everything. That's what this is going to help, right? Then also we have the steps of metastasis. Okay, that's what is going to happen here, right? So we have 8 molecular hallmarks. All the 8 molecular hallmarks are important for me. After the lecture, I want you to take this page, try to recollect maximum possible. Kaleem, you said you have less time. Try to recollect with this. If you can recollect with a single line, you guys are amazing, no? You can easily write a half a page or a 1-page exam. That's enough? Perfect. Now let's go to the first one, self-sufficiency of growth factors. The most important thing is, everything we know normal, we easily can write about abnormality, right? So what is a normal proto-oncogene? A proto-oncogene is nothing but any normal protein, okay? Any normal protein or the DNA or the gene which supports or which helps in cell division. Okay, if someone is going to ask you in Viva, what is a proto-oncogene? Please don't start with saying it causes cancer. Proto-oncogene does not cause cancer. Proto-oncogene is a normal counterpart. Like my skin needs to grow. I need a gene. That is proto-oncogene. When it's getting mutated, yes, I'll end up in a cancer. So we call mutated proto-oncogenes as oncogene. Okay. So whenever it gets mutated, we change the terminology. We call it oncogene. The next question is, what type of mutation? In the genetics chapter, we read about lots, like point mutation can be there, amplification can be there, translocation can be there. Whatever it may be, it can cause a point mutation. Okay. It can be an amplification. That also is possible, right? It can even be a translocation. That also is possible. Any amount of genetic change is possible, but there's only one goal. All of them should increase the function, because normal function is cell division, right? So when there's more function, obviously there'll be more cell division, right? There'll be increased function, or in other words, for a Viva to grab the attention of the examiner, we call it gain of function mutation. Okay, it's a gain of function mutation. Whenever you have a gain of function mutation, we can call it most likely an oncogene. So if a question comes on, write a short note of oncogene. Just use this definition first to start with. Proto-oncogene is something which helps in the normal cell division and growth, and the mutated counterpart, we call it an oncogene. And the types of mutation can be anything, but ultimately the end goal has to be a gain of function mutation. And few examples. In a short note, if you can write 5 solid examples, that is more than enough. Please don't go with Robin's tables here. I'm just going to tell you what is important, what is required. First, RAS. RAS is the most common proto-oncogene mutated. Fine. It's the most common proto-oncogene mutated, or when I say it's mutated, you can also write most common oncogene which is getting mutated. Throughout the body, the most common oncogene is RAS. One we already know. Yes, hi. Mutation will be then the proto-oncogene, which converts them into oncogene. That oncogene causes cancer. Oncogene and proto-oncogene are similarly same. One is mutated, one is normal. Okay, fine. So then when you write RAS, I have 3 subdivisions. Write about KRAS, HRAS, and NRAS. See, most important thing when you write in an exam, you have to tell to the examiner, unfortunately, that yes, I know substances. If you can convince them, yeah, I know it, they will be like, yes, that is more than enough for them to say this kid knows this much. That is more than enough for the exam as well as your understanding of medicine as well, right? So 3 subdivisions. If you write 3 subdivisions, I also want you to remember at least one example for each. KRAS is the most important one. Never forget KRAS. KRAS you'll have in adenocarcinomas of which tumors? Can anyone tell me? Pancreas, colon, and lung. KRAS is the most important thing here, right? If you forget the others, it doesn't matter, but please do not forget KRAS. KRAS is something which is very, very important. Everyone needs to know about KRAS. Fine? Okay? Okay, just give me a second. Someone is texting me. Just a second, guys. The studio person. Great, Subhajit. Great, 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 great. Okay, perfect. So now we'll come to HRAS. HRAS and NRAS is not something which is very important, but if you know HRAS and NRAS, I'll be more than happy. Yes, you can write something, right? Can anyone tell me what are the tumors where you see HRAS? Hi, Kabali. Good evening. Hello, Syed. Great. Can anyone tell me which tumors we'll see HRAS? HRAS is also a mutation which can be seen. I can see them in the bladder tumors and sometimes even in your thyroid lesions, especially in the follicular carcinoma of thyroid. We do see HRAS, but if you look in the Robbins, it will not be written about HRAS in the initial part. It will be covered a little bit later, right? So it doesn't matter that you will see HRAS here also. HRAS is seen in bladder tumors. HRAS can also be seen in kidney tumors. HRAS is also seen in case of your thyroid carcinomas. NRAS, yes, I will see them in the melanomas, and also I'll see in N for neuroblastomas. Fine. So these are a few things which you should not forget, the basic things, right? But KRAS is ultimately important. Other things, even if you forget, it's okay for me to some extent. Fine, done. Now let's go to EGFR. Next condition is ERB-B1, ERB-B2. Both of them come under the epidermal growth factor family, right? So ERB-B1 is this, ERB-B2 is this. If you want to write, please write HER2/neu. HER2/neu is the most important term everyone knows. ERB-B2 is the rest of it, right? EGFR is the other name for ERB-B1. It's seen in lung adenocarcinoma, very important. And if you want to write an extra point, please write that it's seen in lung adenocarcinoma, especially in Asian population. It's more common in Asians compared to a foreigner. That makes it much more important. As an Indian, I need to know about, yes, EGFR mutation lung cancer, right? HER2/neu, you know that here what happens is HER2/neu will get amplified. Amplification is genetic change, what happens? And HER2/neu is seen in breast cancer. Okay, you see them in breast cancer, right? Then JAK2. JAK2 is the receptor for your RBC or your erythropoietin. Erythropoietin comes and sits on JAK2. Now, can anyone tell me what tumors you will see JAK2? Kaleem, Subhajit, Kabali, Syed, what tumors do you see JAK2? If I know that the function, you can easily tell the tumors. If it's going to help in the RBC's division, right? If it's going to help in RBC's division, by default, it causes a tumor which is related to RBC. We call it polycythemia. Don't forget, it's the most commonly seen in polycythemia rubra vera. Polycythemia is nothing but increased RBC. When I call it polycythemia rubra vera, which means the increase in RBC is due to cancer. That's what polycythemia rubra vera means. But yes, polycythemia vera is also more than enough for me, right? Now I said it's RBC. If I say it's RBC, can it also involve WBC and platelets? Might, right? So first, don't forget about polycythemia rubra vera, and also write also seen in chronic myeloproliferative tumors or myeloproliferative lesions. Myelo is for bone marrow, myeloproliferative disorders. Okay, it's also seen in chronic myeloproliferative disorders. Fine. So I see them in two conditions. Never forget polycythemia rubra vera and also remember chronic myeloproliferative disorders. Done? Done. Next, let's go to BRAF. BRAF, the most common mutation. Every examiner will expect this. It's not any BRAF. It's BRAF V600E. This is the particular mutation which I'm going to look for. Other mutations of BRAF is not important for me because the targeted therapy, what I have is also for BRAF V600E, right? Two things, never forget, it is seen in melanoma, right? It's also seen in one more tumor, hairy cell leukemia, right? Melanoma and hairy cell leukemia. Leukemia is a blood tumor and melanoma is your skin lesion. If you want to get extra points, it's also seen in condition called as Langerhans cell histiocytosis. Okay, it's also seen in Langerhans cell histiocytosis. It's also seen in other two conditions, right? Whatever I'm writing in red is an extra pointer, but the black one is bare minimum I want you to remember, right? Everyone, ABL, you know about ABL, the clue I'm going to give. If you're writing, please put your pens down and comment where do you see ABL. The clue is it is seen in BCR-ABL. BCR-ABL is a translocation seen here, right? It's an additional point which you can easily write. We know the BCR-ABL translocation, right? Even in genetics, when we saw the karyotyping and your fish, we talked about BCR-ABL. Where do you see BCR-ABL? BCR-ABL is diagnostic of one condition, which is your chronic myeloid leukemia or CML. Perfect, Subhajit. In CML, what BCR-ABL does is it increases an activity called as tyrosine kinase activity. The tyrosine kinase is the proto-oncogene here, right? There'll be increase in tyrosine kinase activity. When the activity increases, by default, I'm going to have more cell division, which can cause the cancer. Done? Perfect. c-KIT is also actually a tyrosine kinase. So c-KIT is seen in GIST, gastrointestinal stromal tumor, right? Gastro, stomach, intestinal, comes in the intestine, arises from the stroma of the GIT, and then tumor, gastrointestinal stromal tumor. That's about GIST. Fine. It's also seen in seminoma, dysgerminoma. See, seminoma, dysgerminoma are testicular and ovarian tumor. Seminoma happens in testis. The same counterpart, dysgerminoma, happens in the ovary. Fine. That's one. That's also, you see, c-KIT. And also one more condition, hematolymphoid condition called systemic mastocytosis. Fine. Done. Perfect. So we know about few common mutations and few conditions where we see these common mutations. Now, how many of you want to get distinction? Kalam, I want you to comment yes. Passing is fine. Every Tom, Dick and Harry passes, right? Right? So how many of you aim for distinction? Aim always for honors. Aim for 100. Then you'll reach the sky, right? That's what the analogy is. Aim for the sky, stars, you'll reach the sky, right? So if you want to get a distinction or if you want to make the examiner look into your paper a little bit more in detail, this is bare minimum expectation. But the application aspect, whenever you write in pharmacology, pathology, and microbiology, makes the people turn the head, right? No one wants to get a distinction? Come on, guys. I thought you'll definitely say yes. Comment yes if you want a distinction. Believe me, if you comment yes, there's a very likely chance you'll get a distinction. Okay? That is treatment. So whenever I write a proto-oncogene, the targeted therapy is important. BCR-ABL translocation. I can use a drug called as an imatinib. That is important. The targeted therapy is what is going to make the application aspect, because these are paramedical subjects, right? Anat physiobiochem, basic science, path pharma micro paramedical, paraclinical, and then you go for your clinical exams, right? So it is a link, right? Perfect. Done. So you write the application part. So I have told many things here. Actually, all of these has targeted therapy. But if you can remember at least 3-4, that's more than enough now. When you go to pharmacology, you complete cancer chemotherapy, you can write for every drug, right? So now, at least few things to remember. HER2/neu. We have antibodies to HER2/neu. We have anti-HER2/neu as a treatment, and the treatment is, the drug is trastuzumab, which is anti-HER2/neu antibodies. So when you have anti-HER2/neu antibodies that can go, I give to a patient, HER2/neu is more HER2/neu is the problem. This antibody goes and binds, destroys HER2/neu, cancer automatically comes back to normal, right? JAK2, I have a targeted therapy. We have an anti-JAK2, which is ruxolitinib. Okay? 1, 2 is more than enough. If you write 1 or 2, that will definitely make the examiner think that, okay, this is special kit. This have made effort to write more, that will definitely reward. BRAF mutation, I have multiple drugs. The newer drug which is working beautifully is darafinib. We had older one called as vemurafenib. Darafinib is the congener working beautifully, right? BCR-ABL as well as c-KIT. Actually, both are tyrosine kinase activity. Can anyone tell me what is the drug against BCR-ABL? I asked you the same question in Nischay, and I also taught you that same in Nischay, right? Both of them, we have or we call it a tyrosine kinase inhibitor. TK is a short form, which is nothing but tyrosine kinase ka inhibitor. Come on, guys, what is the drug? The drug is your imatinib. So in a short note, I have every aspect covered. I had a little bit introduction of what is a proto-oncogene. We came to what is an oncogene. We told what will be the type of mutation. We had 5-6 genes to be mentioned, and also the application part. If you can write in the form of a table, the gene, the cancer, and the treatment, that will be great. If you're not that much good in presentation, right? Just the gene, bullet points, the cancers, one more heading, treatment, give the treatment, right? That's more than enough to know for the exam, internal assessment, that's all. But to read in pathology, we'll have lots more. We'll cover in the main batch, right? Now let's go to the second hallmark. Any doubts? Guys, any doubts in the first hallmark? Let me know. If yes, I'll address the doubts. If no, we'll go to the second hallmark. What do you guys think? Any doubts? Silent. Why are you silent? I know that you guys are not silent. Come on. This generation, the one thing which I love about this generation is you're very, very vocal, and that's something which makes you better and also us better, right? Now let's go to tumor suppressor gene. So tumor suppressor gene is the second hallmark where we compare it to ineffective to growth inhibitory signals or insensitive to growth inhibitory signals, right? So you have to write the same thing. If the question says write a short note on tumor suppressor gene, or if the question says write a short note why cancers are insensitive to growth inhibitory signals. Both means one and the same, right? Fine. So when I say growth inhibitory signals, what it is, right? Great. First, what is a tumor suppressor gene? Same template. Tell me when it will cause a cancer. Then add extra 1 point whenever you're writing about tumor suppressor gene. Without mentioning Knudson's two-hit hypothesis, there's no tumor suppressor gene question. Even in Viva, same thing will happen. And few diseases and most important cancers which I want you to remember, right? What is it? So tumor suppressor genes are again normal genes and its products. When I say products, the protein what the gene creates, which actually inhibit cell division. In one way or the other, they inhibit cell division. They can directly act on the cell cycle, stop the G1 to S phase, G2 to M phase, or they can act in a different way. They are going to inhibit or reduce cell division, that it is. So when it is going to cause a cancer, the type of mutation, right? Again, it can be anything. It can be a point mutation, okay? It can be a translocation, it can be a deletion, right? So, but the only thing is, like so we just said, we should have a loss of function mutation. A loss of function mutation is must, because a normal function is to suppress the cell growth. If the suppression is lost, I'll have more cell division. That is the tumor suppressor gene, right? Okay. Now let's go to Knudson two-hit hypothesis. How many of university exam has 3 marks? If there's a 3 mark in your university exam paper, I would say Knudson two-hit hypothesis is a very good question to ask in a 3 mark, right? Because just tiny bit to write, and every point you write is important for application aspect, right? So we have something called a Knudson two-hit hypothesis. So Knudson two-hit hypothesis said that it is first true for every tumor suppressor gene. But please comment what comes to your mind. Which gene comes to your mind when you think of Knudson's two-hit hypothesis? In Robbins or in your Ramdas Noyak or in your Harshmogan, whatever book you read, it will always mention retinoblastoma, right? Knudson two-hit hypothesis was discovered in retinoblastoma. It was discovered in the RB gene. Doesn't mean that it's seen only in RB gene. It is seen in every tumor suppressor gene exhibits or shows Knudson's two-hit hypothesis. Knudson discovered that in retinoblastoma. What does it mean? 2 important points to write here. First, explain what is Knudson two-hit hypothesis, and there'll be one term which is important, which will be there in entire pathology book to say, this is Knudson two-hit hypothesis, right? So Knudson two-hit hypothesis said that for any person to develop cancer, okay, due to tumor suppressor gene mutation. I said that it is loss of function mutation. Right? Two alleles are there of every gene, right? Retinoblastoma is 2, P53 is 2, everything is 2. If one is gone, can I say the other one can stop cancer? Yes, no, maybe. What do you guys think? Normal job is to stop cell division. One is deleted, mutated, gone, lost. Can the other still function? It will function. If it functions, will it stop cell division? It will. So when will I have cancer? To develop cancer, one mutation is not enough. I need 2 mutations, right? To develop cancer due to any tumor suppressor gene mutation, you need biallelic loss. Biallelic, both the alleles should be lost. Only then you will have a cancer. That is very, very important for Knudson two-hit hypothesis. First point. Second, how it will be written in textbooks or how the MCQs might come. For this, I need your help. You guys have been mute spectators. Open up. Both allele being same, we call it homozygous or heterozygous. One allele is mutated, other alleles not mutated. We call it homozygous or heterozygous. Both same is homo. One mutated, one normal is hetero. So for me, this is normal. The first mutation happened. When will I have cancer? When the second mutation also happened, right? So this is heterozygous, one mutated, one normal. When will I have cancer? Loss of heterozygosity. Very, very important. Either biallelic loss, or we use the term loss of heterozygosity. This is important. LOH. This term will be used throughout the Robbins pathology, throughout Harrison. Loss of heterozygosity in tumor suppressor gene causes cancer, or a biallelic loss in any tumor suppressor gene causes cancer. There's no exceptions at all here, right? Now, at least 5-6 genes I want you to remember. If possible, remember more. But for a university exam, if you write these 5-6 genes, if possible, the location of the gene, what is the function of the gene, and what cancers do they cause. It's a simple thing. If you can remember this, that will be more than enough, right? So retinoblastoma, it is seen in chromosome 13. Retinoblastoma is also called as a governor of cell division or cell proliferation. Fine. It's the governor of cell proliferation or cell division. That is the normal function of retinoblastoma. If retinoblastoma has a mutation, loss of function only, right? For that I need to know normal. Normal RB function is to stop a cell from G1 to S phase. It's to stop a cell from moving from G1 to S. So when you have a mutation, I am writing in short forms, loss of function mutation, but for you in an exam, please write elaboratory. Loss of function mutation, so there'll be no one to stop a cell from G1 to S phase. So there'll be cells automatically move from G1 to S phase. Easily they will transit. Once they easily transit G1 to S phase, automatically there'll be uncontrolled cell division. You'll have an uncontrolled cell division. That's what will happen in case of an retinoblastoma. Clear? Done? Perfect. So now we know about retinoblastoma. What tumors we'll see them? As the name says, we'll see them in retinoblastoma, and the tumors, the space is not enough, so I'm writing a little bit upper, right? Tumors, I'll see them in retinoblastoma 1. Second one, I'll see them in osteosarcoma, the bone tumors. 3 points, enough for per gene. More than enough. You can write easily 2-3 points for every gene. If you compile that for a 5 mark, it's more than enough. If it's an essay, don't write beyond this for an essay, because essay might have more molecular hallmarks, not one molecular hallmark, right? P53. The ideal name is TP53. TP53 is a gene name. P53 is a protein's name, right? Again, same template, chromosome 17. If you want, write 17p13, great. And the job and the name is guardian angel of all genome. It's a guardian angel of genome. Once you know it's a guardian angel of genome, I need to know the normal function. The normal function is P53, what it does is P53 makes sure that the cell division, whenever cell division happens, there will be mutation. P53 job is to pick up the mutation and correct the mutation. That's what P53 do. The normal function of P53 is whenever there is any mutation in any cell across the genome, P53 will stop the cycle and they will correct it. That's what they do. If the mutation is not correctable, if it's a very, very difficult or a terminal mutation, right? It's not able to correct the mutation. P53 will activate a factor called as PUMA. You must have read in apoptosis, right? Which causes apoptosis. Again, this is normal function of P53. So now, without P53, any mutation in the body will go unchecked, right? So when you have P53 loss, P53 problem is loss of function mutation. P53 loss will result in more and more and more and more mutation. So obviously when more and more mutation accumulate, it is going to end up in cancer or uncontrolled cell division, right? Can anyone tell me what is the gene, what is the syndrome called as? What's the syndrome called as when it's P53 mutated? P53 mutation is called as your Lymph syndrome, right? So a congenital P53 loss is Lymph syndrome, and in Lymph syndrome, you will have a combination of breast parenchymal tumors, CNS tumors, leukemias, and sarcomas. If you see these combinations, when I say sarcoma, could be an osteosarcoma, could be a leiomyosarcoma, could be a fibrosarcoma, right? When I see this combination, I'll definitely think of a tumor suppressor gene mutation, right? That's a p53 mutation, right? Normal location, the name, normal function, what will happen is mutated, one inherited cancer syndrome. It's more than enough, right? I have written like this, but the content available there can easily be extrapolated to half a page of your paper, right? Next is CDH1. CDH1 gene, the normal function is they code for something called an E-cadherin. So E-cadherin has two jobs. One, it's a cell adhesion molecule, right? It's like a desmosome, semi-desmosomes. That's the first part. Apart from being a cell adhesion molecule, E-cadherin also does one more important thing. Whenever there's an adhesion, it makes sure the contact will stop cell division, right? We call it contact inhibition of growth. So you'll have contact inhibition of growth. So when I have contact inhibition of growth, that is the normal function. Again, the same problem, I'll have loss of function mutation. So whenever I have a loss of function mutation, I'll have loss of contact inhibition of growth. When there's no contact, it will not stop division, it will divide more. Assuming contact, I have two cells here. This cell dies, goes, no contact, a new cell comes. That's what happens in loss of function mutation. There is loss of contact inhibition. Please don't forget this. It's not about the cell adhesion molecule. It's the loss of contact inhibition which causes the cancer, right? Remember that, loss of contact inhibition. So then what tumors will I see? Your E-cadherin loss. Two tumors, never forget. One is lobular carcinoma of breast. That's one, right? We have two tumors in the breast parenchyma, ductal carcinoma of breast, lobular carcinoma of breast. Because in the breast parenchyma normally have duct and lobules. Lobular carcinoma and ductal carcinoma, right? Second tumor, not any gastric carcinoma, diffuse gastric carcinoma. Okay, perfect. So this, if E-cadherin alone comes as a 5 mark, I can add one more. Like I said, implication makes a change. Application makes a change, right? So most important thing is, most of the tumors with an E-cadherin loss has a tendency for early metastasis because they are already separated from one another. It can easily go to lymph node, it can easily go to liver, it can easily go to lung. That's important for both lobular carcinoma of breast and both diffuse gastric carcinoma. It can early spread, divide a lot, right? Perfect, done. Then VHL, one hippolyndo seen in chromosome 3. The normal function of one hippolyndo is to suppress a growth factor called as an HIF, hypoxia inducible factor, it's HIF, and one hippolyndo syndrome. Remember, one hippolyndo syndrome can come in a 2 mark. The 5 or 6 presentation of one hippolyndo syndrome, you have to know about it. One hippolyndo syndrome, the first and the most important thing is, don't forget, we'll have clear cell, renal cell carcinoma. You will have multiple hemangiomas. When I say hemangioma, you'll have in the retina. There's a lesion in the cerebellum. So we have cerebellar hemangioblastomas. Fine. Okay. You'll have multiple other hemangiomas in your lungs, in liver, everywhere. It's hypoxia inducible factor. More and more of hypoxia inducible factor, my body thinks there's a need for more blood supply. So more blood vessels will come into place, right? So you'll have more and more hemangiomas in lungs, liver, spleen, everywhere, right? Blood vessel tumor, that's all. Okay. Two more findings, never forget. The fifth one is lots of blood vessels in the body. Automatically the substance which control blood vessel, catecholamines, will increase production. So adrenal medulla will be overburdened. So we'll have pheochromocytoma, right? That will be there. And last but not the least, sixth one, I'm writing in red because not a must know, but if you write, great. There is a classical paraneoplastic syndrome. Whenever this hypoxia inducible factor, you will have more and more erythropoietin production because my body has to correct your hypoxia, right? So you'll also end up in having polycythemia vera. This is not neoplastic, it's just a polycythemia. This is a PNS for paraneoplastic syndrome. We'll look at that very, very soon, fine? Perfect, right? So these are the 6 features of one hippolyndo syndrome seen in chromosome 3p. It's a tumor suppressor gene, same Knudson 2-hit hypothesis goes, right? Next we'll look at your APC beta catenin. APC beta catenin, it's seen in normal chromosome 5. APC beta catenin is mutated in a syndrome called as Familial Adenomatous Polyposis, FAP. FAP is a short form. Now it might be difficult, but go to third year, fourth year, FAP will be very, very simple. It's that's how it is. You'll definitely know that, right? Now, so what is the normal function of APC beta content, right? Normal function of APC is APC binds to beta catenin and it will destroy it. Beta catenin is a proto-oncogene. Beta catenin is required for cell growth, right? So whenever I have loss of function mutation of APC, so what happens? This beta catenin is not lost, the beta catenin is free. When the beta catenin is free, it goes to the nucleus and it causes increased uncontrolled cell division or uncontrolled cell growth. Okay, that's my pathogenesis. If I know APC's pathogenesis, and I know about familial adenomatous polyposis, it makes sense for me to write a little bit about the syndrome. Like we wrote about Leaf Romani, congenital retinoblastoma. FAP also has multiple variants. FAP, I need a minimum of 100 polyps to diagnose. Minimum 100 polyps in intestine, diagnosis of FAP, familial adenomatous polyposis. Sometimes it's a dominant inheritance. I'll have less penetrance. We call it attenuated FAP. Attenuation is less, right? Attenuated FAP can have approximately minimum 30 polyps also is enough for me for diagnosis. Not one, multiple only, but not that much of 100. That's your incomplete penetrance, right? If you remember autosomal dominant inheritance, we also have variable expressivity. We have a syndrome called as Turcot syndrome. Turcot is FAP, which means polyps. I remember Turcot like turban. CNS tumors, right? Plus CNS lesions. I am not wanting you to write what CNS lesions, just CNS lesions enough, right? Next is Gardner. Gardening, so there's a possibility can get prick in your hands and foot. So same FAP plus skin and bone tumors. That's Gardner, right? These are stupid ways to remember, but trust me, these stupid things are the one which remembers in your exam, which will save your life, right? Perfect. So we know about FAP. Normal, how it functions when it's abnormal, and few variations, right? Done? Perfect. Now let's go to SKT11. SKT11's other name is LKB1. It's a serine threonine kinase. It's also a kinase, that's all, fine. So STK11, the normal function is to make sure it helps in maintaining polarity. That's the normal function of STK11. Again, its loss of function mutation is going to be there here also. There'll be altered polarity, that's all, which causes altered polarity, that's one. At the same time, it also increases cell division because every tumor suppressor gene will increase cell division by default. STK11 is mutated in a very known syndrome called as Peutz-Jeghers syndrome. Peutz-Jeghers syndrome can come in a viva because pathologists per se are obsessed about this, right? Peutz-Jeghers syndrome, what all will I see in Peutz-Jeghers syndrome? One, I'll have here Peutz-Jeghers polyp, right? Can anyone tell me what type of polyp you will see in Peutz-Jeghers syndrome? Sorry for it. What type of polyp do you see in Peutz-Jeghers syndrome? You see a hematogenous polyp, right? So the features of Peutz-Jeghers syndrome are you will see lots and lots of hematogenous polyps. If you remember hematogenous polyps, there will be lost polarity. Everything will be wishy-washy. The mucosa will be on top. Muscle will come between them. Right? That's hematogenous polyp. Next, you will have tumors in your, it's a syndrome, right? There will be increased tumors in the breast parenchyma. Never forget pancreas. This even came in an NEET PG exam. Very important. And the most important thing, these patients will have altered polarity even in the skin of the oral cavity. That's also part of GIT, right? So what happens? You'll have oral mucocutaneous hyperpigmentation. Fine. That's classical for your Peutz-Jeghers syndrome or Peutz-Jeghers polyp, right? Again, this might look like one slide. The amount of information what you have in this slide is enough for you to write each one of them as a short note. So how you have to write as a short note is, most of you ask me, how do I write in an exam? I know it, but how do I write in an exam? Let's assume there's a question on, write a short note on APC gene or familial adenomatous polyposis. The first word is APC is a tumor suppressor gene. When I say tumor suppressor gene, can I say this point holds true? Yes, it is. The normal function of APC is to suppress cell division by destroying beta-catenin. When APC gets mutated, it has to be a loss of function mutation. Not just that, any tumor suppressor gene will follow Knudson, so you can write that APC also follows Knudson 2-hit hypothesis, which means only when there's a biallelic loss, I'll have cancer. What cancer? Most likely colonic cancer. If it is inherited, I have a syndrome called as FAP. And FAP, I have 4 different subtypes. That's more than enough to write a short note. It's about how I present in an exam, right? The presentation is very, very important. I'll just take one slide to tell you how to present in an exam, right? Just a question on FAP, familial adenomatous polyposis FAP. How many of you feel that presenting in an exam is tough? Yes, no, maybe. For everyone who feels presenting in an exam is tough, you have to know what to write because you already have abundance of knowledge, right? You don't lack knowledge. There's too much of knowledge or too much of information is the problem of your generation. Not able to filter and put it in the paper. If we ask you rarest of the rarest syndrome, you'll answer. Rarest of the rarest gene, you'll answer. Ask you and write some simple important things, you fumble. Right? Let's put into paper, right? So when I say short note on APC, first I'll write the gene location. If you want to write the gene location and write it is tumor suppressor gene or proto-oncogene. Second, I'll write the normal function. In this case, normal function is your destruction of your beta-catenin, right? Third, I'll write what will happen when there's a mutated APC. Here is where I'll use the loss of function mutation. I'll use your Knudson's 2-hit hypothesis here. Talk about that I need a biallelic loss. I need a loss of heterozygosity to cause the cancer, right? Fourth, the tumors it will cause. Primary cancer is colonic cancer. That's a primary tumor. Fifth, is there any inherited condition? The inherited condition is familial adenomatous polyposis. Write that. Write about attenuated FFP. Write about the variant Turcot. Write about the variant Gardner. Easily more than a page. More than a page of solid pointers. If you have a big handwriting or if you can draw, because if you look at Robbins and our classes, we have drawn the normal function. It'll take an extra page. This is how you structure a paper. This is how you structure a short note. Same whatever you read in the class, but structure it differently. That's more than enough. No one is looking for word by word answer paper from Robbins. If you think that your pathology professor will not give you marks if you write in your own words, trust me, none of the pathology professor knows what's the word in Robbins. I know what is there. If you write in any way, I'm okay with that. Fine. Diagrams is not mandatory. Don't take H&E pencil. Take a violet color stick pen and a pink color stick pen. Draw with that. That's more than enough. I want descriptive diagrams than your beautiful diagrams. That's it. Fine. Perfect. Now let's go to next guy. Evasion of immune response. Evasion of immune response can come in a short note. There's a possibility because this is the latest hallmark. So there's lots of buzz around that. So there's a possibility it can come as a short note. First thing is, why should cancer pick up my tumor cells and destroy them? Why? Because it's a foreign agent. No. Cancer is self-protein. Nah? Can I say HER2 is seen in my body? Yes. So why should it destroy? Cytokeratin is seen in my body. Why should it destroy? It's a self-antigen. Nah? It's a self-antigen, right? So first question is, why cancers are considered pathogenic in my body? Or why cancers are immunogenic so that it has to elicit an immune response? The first answer for that is, some cancers, not all cancers, will have viral antigens. It's easy to remember. Foreign, so it can easily destroy, right? Have oncogenic viruses, oncogenic bacteria, oncogenic parasites. So obviously those DNA is there inside my body will consider it foreign and it will destroy. First answer, right? Second, I have excess production of proteins, right? So when I have excess production, most of the proto-oncogene, for example, HER2 itself, it's amplification, right? So this excess production of proteins, this causes intracellular protein accumulation. You know that if there's an excess of intracellular protein accumulation, my body will consider it as foreign and try to kill it. That's how we pick up viral proteins and kill it, right? That's how we do it. My body should reject it, right? Third, there'll be altered or mutated protein. So why altered or mutated protein should cause a problem? Simple. This is my normal protein. Mutation came, removed the cap, looking as a new protein. My body will consider as a new protein and will try to destroy it, right? So because of these reasons, my body will consider it as foreign. Who will consider? All these problems are inside the cell. So only three things will consider. My immune cells, which will consider or which will fight against cancer, are CD4 T cells, CD8 T cells, and NK cells. Rest of it will not. Neutrophil will not go and destroy a virus. Lymphocytes destroy a virus. NK cells destroy a virus. Right? Macrophage does not go and target the intracellular proteins. CD4, CD8 does. Right? So I know why it's pathogenic, and I know what immune cell should destroy it. The next heading should be, how do they evade cancer then? How do they evade immune response? Answer is pretty simple. We'll divide into two. The first thing is, how do they evade CD8? The second thing is, how do they evade CD4? Actually, they don't evade NK cells. NK cell is something which still works. NK cell is something which can still kill cancer cells, right? But they're not that strong. How do they evade CD8? For that, I need to read about normal CD8, right? So the way normal CD8 acts is, normal CD8, if I have a CD8 T cell, right, and have any normal nucleated cell which has an MHC molecule. If I have, let's say, I have a virus infection. So this MHC molecule along with the virus will be altered. This altered MHC is the signal for activation. It will activate CD8 T cells. Once CD8 is activated, they secrete two guys called as perforin and granzyme. Then they create perforin granzyme that will go and destroy the virus infected cells. That's why we call CD8 as cytotoxic T cells. Right? In an exam also write the same way. Need not write in the form of lines. This is more than enough. Write the same way in the exam also. Now, how do I evade? That's the most important thing. So cancer cells escape by simply destroying or removing MHC1. Once it destroys MHC1 molecule from a tumor cell, as the googly. If the MHC molecule is destroyed, CD8 T cell can't even recognize it. They can't even recognize cancer cell. Only when they recognize, there's a possibility I can kill them. No, here they can't even recognize the tumor cell, can't even recognize the cancer cell. So there's no way they can't kill the tumor cell. But yes, NK cell will still recognize them. For NK cell, the trigger is altered MHC or loss of MHC. That will go and destroy still, right? But the problem here is, this destroyed MHC molecule is actually the trigger for NK cell. NK cell will identify them and NK cell will destroy them. But the problem is, NK cell is weak. They are an innate immune response. Any innate immune response, unfortunately, is weak for me. They don't have a memory. They don't have a secondary heightened response. Done? This is how my NK cells, CD8 cells is going to escape immune response. Fine? Just give me a second. Okay, let's go back. So now how CD4 escapes it. So CD4 cells, again, we know the normal. This is an image from Robbins. We read in the immunology chapter, right? So a normal antigen presenting cell and a normal CD4 T cells. The antigen, what the antigen presenting cell presents with the help of MHC2 molecule, binds to something called T cell receptor. This entire Greek and Latin names now, that is T cell receptor. So this gives me signal 1. Next is my co-stimulatory molecules. Co-stimulatory molecules are must for me to give me signal 2. For CD4 activation, right? For CD4 activation, both signal 1 and signal 2 are must. Again, this is normal. I need activation of both signal 1 as well as signal 2. So how do I escape? Try to destroy one. Unfortunately, I cannot destroy signal 1 because signal 1 is the one which gave the tumor's antigen to my CD4. I cannot remove that. So what do? I destroy signal 2. So how does a tumor cell escape immune system? Escape CD4 mediated destruction. So whenever an antigen presenting cell presents a tumor antigen to my CD4 T cell, that gives my first signal. Na? So this CD4 is going to release two molecules, CTLA4, PD1 or PDL1. It's fine, any of them. This CTLA4, PD1, PDL1 is going to destroy signal 2. It'll go and bind with them, make sure the signal 2 co-stimulatory molecule does not work. Once it destroys signal 2, what will happen automatically? There will be no CD4 activation. There's no CD4 activation. That's unfortunately how they escape. Sure, Saurabh, I won't. Fine. We'll cover, see, my most of the one-shot series were short because I wanted to be as a review and not as a lecture. This I'm going a bit in detail because I've not covered the neoplasia for you in the Nischay batch. So this might help you for your upcoming university exams, upcoming internal assessment, fine? Now, like I said, learning pathogenesis has to have an application. If it does not have an application, it is waste. How do I apply them? Application is nothing but a concept called as an immunotherapy. Okay, so a concept called an immunotherapy. What do I do in immunotherapy is I have antibodies to CTLA4. The drug name was ipilimumab. And I have antibodies to PD1 or PDL1. The drug name is nivolumab. So this ipilimumab and nivolumab, what they do is they are going to make sure the CD4 now will actually start recognizing and they start destroying tumor antigens and tumor cells. Because they remove CTLA4 PD1, my CD4 will recognize, this is not a self antigen, there is something foreign, signal 2 is present, let me go and destroy it. But the only side effect, which you have to remember, adverse drug reactions, ADR stands for adverse drug reactions. I hope you must have known that from your pharmacology, right? So adverse drug reactions is, I'll have lots and lots of autoimmune reactions. Autoimmune reactions will happen. One of the important autoimmune reactions worth mentioning here is ANCA-mediated vasculitis. There's lots and lots of cases of ANCA-mediated vasculitis with respect to this. See, in the Nischay batch, I also must have told you it reverses the graying of hair. That is not for you to write in the exam. That's to develop curiosity. There are some things which I say in the class for you to feel that medicine is wow. Don't put in the exam hall. In exam, we'll write what we know, get the mark, go away, learn whatever you want in your life, right? This is more than enough for your evasion of immune response. But NK cells still will kill cancer, not that efficient. That's why cancer is killing human beings and my immune system is not taking care of that. Fine? Done. So that's about your evasion of immune response. The most anticipated one, metastasis. Because mets is something which can definitely come in, and we have not covered that in Nischay, right? So metastasis, first definition. Guys, let's open up a little bit now. Can anyone tell me what do you think is the definition of metastasis? Because for everything I need a definition. Meta is change. Stasis is site. Mets is nothing but spread of tumors from the site of origin to any site which is physically discontinuous. The word physically discontinuous is very, very, very important, right? Mets by definition, meta is change, stasis is from its original, stasis is hemostasis, from its original going outside, right? It's nothing but spread of tumor, right? It's simple, to sites which are physically discontinuous. That's what is metastasis. This word is very, very important. It should be physically discontinuous. What do I mean by that? I'll give you a simple example. Let's say there's a patient with thyroid cancer. Can it go to the muscles here? Can it spread to the muscles? Yes, no, maybe. How many of you guys think yes, it can? You guys have to answer this question. Put Y or N. That's more than enough for me. I have a patient with thyroid cancer. Can it go to these muscles? You must have read about all these muscles, right? Hyoid muscles and everything. Can it go? It can. This is not metastasis. This is extension. It is physically continuous. It's not discontinuous. But a thyroid cancer going to my jugulodigastric node, physically discontinuous. Thyroid cancer going to lung, physically discontinuous. That's why this word is very, very important, right? It has to be physically discontinuous. That's important. A spread of a tumor to a site which is physically discontinuous from the primary tumor is called as metastasis. And Mets is undoubtedly a hallmark of cancer, hallmark of malignancy. If it's metastasis seen, by default it is malignant. These are actually exceptions for MCQs or for Viva. There's a cancer which does not spread. Never forget this. Basal cell carcinoma. A benign tumor which might spread. Again, don't write this in a theory exam. If they ask in a Viva, tell them there are evidences we say that leiomyoma has spread. Okay. These are exceptions. Exceptions are not for the routine. Exceptions are when they are asked. Okay. So we know the metastasis, the definition, and a few exceptions, right? Now we'll look at the routes of spread. Where do they spread? The next is steps. How do they spread? Fine. First is lymphatic. The most common route of metastasis is lymphatics. There are two cancers, na? One is carcinoma, one is sarcoma. Sarc means muscle or fleshy. When you press a muscle, fleshy, lots of blood vessels. Sarc means fleshy, lots of blood vessels. So sarcoma prefers which route? Lymphatic or hematogenous? Hematogenous, right? So most common preferred by, it is preferred by carcinomas. It's undoubtedly preferred by carcinomas. Breast cancer goes to axillary lymph node. Best example. Write an example. Breast cancer can definitely go to your axillary lymph nodes. Thyroid cancer can go to your cervical lymph nodes. That's metastasis. Lymphatic spread. That's all. Done? Perfect. So, okay. So, hematogenous route is not the common route, but hematogenous route is one of the important reasons why lung metastasis and liver metastasis happen. It can spread to the lung and to the liver. Most importantly, it is done by your sarcomas. It is preferred by sarcomas, by mesenchymal tissue because they are fleshy and they go. Exceptions are always the rule. There are few sarcomas which don't go via hematogenous. These are the sarcomas which also spread to lymph nodes. These are actually sarcomas, but they spread to lymph nodes or lymphatic spread. Right? Scare, synovial sarcoma, clear cell sarcoma, angiosarcoma, rhabdomyosarcoma, and scare, epithelioid sarcoma. It's not an hepatoid sarcoma, epithelioid sarcoma. Please stay in that alone. Fine. So these are few things which will make, these are all sarcomas, but still they go to a lymph node. That's an exception. Exceptions can come in a Viva. Fine. Right. Any one of them also enough. If you can remember all, great. Synovial, clear cell, angio, rhabdomyo, and epithelioid. All sarcomas can go to your lymph nodes also. In addition to that, it also will go to lymphatics, hematogenous spread. Fine. Next. First, two basic things are done. I need excitement, no? So, life is like shooting a reel. Sudden, a hook. Slow, a hook. The same way here. Boring two spreads. Write a sentinel lymph node. Will grab the attention. So, what is a sentinel lymph node? Sentinel lymph node is nothing but the first lymph node, okay, which drains a cancer site. These are things which can come in a Viva. They might ask you what is sentinel lymph node biopsy and its significance. Or you have something called as an explain why, right? Why is sentinel lymph node biopsy important? Give a 2 or 3 mark answer for it. Sentinel lymph node is the first lymph node to which a cancer drains. Okay, perfect. So now I'll explain with a tiny bit of a diagram. Like, let's assume that there's a breast cancer here and there's an axillary lymph node here. Fine. There's a breast cancer, which is here. So let's say this is the first lymph node, it drains to. If you remember, axilla has lots of groups of lymph nodes, anterior, posterior, medial, everything is there, right? But this is the first lymph node to which it drains. Let's say this lymph node is positive for cancer. Should I remove that by surgery or not? I'm doing a surgery. The lymph node is positive for cancer. Should I remove the lymph node or not? I should remove the lymph node, right? So if it's positive for cancer, my treatment, R-axis for treatment is mastectomy. Mastectomy is removal of the breast parenchyma plus axillary node dissection. Axillary node dissection is just remove the lymph nodes. That's what it means by axillary node dissection. If this part is negative for cancer, okay? Let's assume it's negative for cancer. How many of you think you should remove the lymph node? Tell yes or no. There's a very simple one. Everyone, Samrat, Jessica, Saurabh, Subhajit, answer. Have to remove, should not remove. If the axillary lymph node is negative for cancer, I should remove or not? I need not. Because it's the first node, right? If the first node does not have cancer, I need not remove the rest. Logic is simple. If the first node is not involved, I don't remove the rest. As simple as that. If it's negative for cancer, my treatment is I go for only mastectomy. This is very, very important because if you remove the axillary lymph node, what will happen to the lymphatic drainage of the hand? Forever edematous, right? It's a very morbid condition for the patient, very tough to live because it will not drain, right? So if it's only involved, I remove it. That's why sentinel lymph node is very, very important for me. So how do I do it? How do I know it's important? How do I know it's involved or not? That's where sentinel lymph node biopsy comes. This is an intraoperative procedure. There are lots of procedures available to identify sentinel lymph node biopsy. I'm going to tell you the easiest one. There are hi-fi things also. When you go to surgery, they'll talk about that. The simple one for undergraduate, we'll talk about that, right? So what I do is intraoperatively, during surgery, you inject methylene blue. You inject methylene blue into the cancer, not in the lymph node, in the cancer, which means I inject methylene blue here. Then dye, right? It'll go via lymphatics. Then I look for the first node which turns blue. Then they take a biopsy. Give it to the pathologist for something called a frozen section. Remember, we read that in the first lecture. Frozen section, I have to give the report in 20 minutes. It's intraoperative. In the frozen section, I will tell if the lymph node, LN is for lymph node, is positive for the cancer or negative for the cancer. Based on that, the treatment happens. Done? This is sentinel lymph node biopsy. Very, very likely chance can come in a viva or in explain why. I think your universities all have explained why, right? Methylene blue, there are something called a radio tracer dye using gamma camera. Multiple ways are there. This is the easiest way. Even if you go to your college, if you have access to your OTs, I hope you will start going to OTs. You might see breast cancers where they might do this procedure in later life. You can easily correlate, right? That's the importance of sentinel lymph node biopsy because it will change my management. Agar it's involved, remove. Not involved, wait. Don't remove, just follow, right? Perfect. No doubts, clear, very sure shot. It might come in an exam. This internal exam will have this question either in Viva or in reasoning Y or in MCQ. Fine, done. Now, next. So we know about lymphatic spread. We know about hematogenous spread. We'll go to the next one, which is seeding of body cavities. So what a seeding of body cavities means? It's a direct spread, right? Seeding of body cavity is nothing but a direct spread. So for example, my lung cancer can go into your pleural space. Your cardiac cancer can go to your pericardial space. Seeding of body cavities. It's a seromic cavity, right? In other words, What will be there in Robbins? And most likely they'll ask in the exam also. Your intra-abdominal cancer can go to your peritoneal space or peritoneal fluid or your ascitic fluid. There's one specific example which they ask, which is nothing but pseudomyxoma peritonei. Okay, pseudomyxoma peritonei. Pseudo means false. It's not actually a myxoma. It's a mucin secreting carcinoma, right? What happens here is mucin secreting ovarian or appendicular or colonic tumors will rupture, or the mucin secreting cells will enter the peritoneal space. The entire peritoneum space involved with mucin secreting tumor cells, right? From that, the entire peritoneal space will have the cancer spread. This is stage 4. Can't do anything. If you remember anatomy of abdomen, very difficult, na? Lots of hidden spaces are there. How will you go and remove mucin every single cell from the abdomen? You can't. It's a stage 4 cancer. Very bad prognosis. Remember that, right? What is pseudomyxoma peritonei? It's a terminal stage of cancer which happens in intra-abdominal mucin secreting carcinoma, where from appendicular, colonic, ovarian. These are 3 common things which can secrete mucin in the abdomen. Stomach also rarely, which will rupture and spread throughout the abdomen. It looks like a myxoma, so we call it a pseudomyxoma peritonei. Done? Perfect. Now this is for to pass. Again, goal is never to pass. Goal is to excel. Extra pointers. There are a few special type of metastasis. One is called Krukenberg's, drop, and intravascular growth, right? What is Krukenberg? Krukenberg is secondaries to ovaries. That's called as in Krukenberg's tumor, right? Just a second. Sorry, no, it's not proper. Fine. So Krukenberg's tumor is secondaries to ovary. Tumors can go and spread and involve the ovary, right? So what do we mean by secondaries to ovaries? Tumors from breast parenchyma, especially lobular carcinoma of breast, and tumors from diffuse gastric cancer. Okay? Can anyone, if you've been there with me for 1 hour, let's see if you can answer that. Can you see any similarities here? If you answer, I'll send you a chocolate. If you come to Chennai, I'll give you a chocolate or give you a big treat only. What's the similarity between these two? There's a similarity. That's the only reason this happens. Correlation makes you a boss. Reading makes you okay. I want you to be the boss. Both of them had CDH1 loss, right? So what happens is in both of them, the tumor cells are separated. They're all separated like this. They are not together. They are separated because both of them had CDH1 loss or E-cadherin loss. So what happens is, if you remember normal anatomy, stomach drainage is to celiac plexus, right? Celiac plexus goes to your azygos, hemiazygos, and goes to your thoracic trunk, right? Great, Tabish. That's how normal. Because CDH1 is lost, it's all over the body. So it can go into retrograde fashion. Antegrade is normal to a thoracic trunk. That is normal spread. But here it goes reverse, retrograde. Retrograde is reverse. Retrograde lymphatics spread. Once it goes to retrograde, abdomen, celiac plexus goes down. Ovaries are there. Ovaries have ovulation, enters inside, involves. That's all, right? Retrograde lymphatic spread goes to the ovary and involves the ovary, right? This can come in 1 mark. What's the reason for Krukenberg's metastasis? It's retrograde lymphatic spread. Fine, perfect. Then drop metastasis. Simple. Drops. That's all. So you have a cerebellum, right? And you have a medulla oblongata and spinal cord. So if you have a tumor from the cerebellum, there's a possibility it can drop, just drop along the spinal cord, right? So this tumor called as in medulloblastoma. There are many tumors which can spread like this, but medulloblastoma can drop and spreads along the spinal column. Okay, that's drop metastasis. Fine. As simple as that. That's just drop metastasis. Got it? Done. Now, this can be there for any CNS tumor. But here, it's common. It drops there. We call it drop metastasis, right? Next is intravascular growth. Please remember, intravascular growth is very different from hematogenous spread. Here it grows into the vessel, right? Seen in two tumors, hepatocellular carcinoma, renal cellular carcinoma. What do I mean by that? This is, let's say, this is your renal vein. Okay. If you remember the tributary of renal vein, it's a tributary of IVC, right? Okay. Hi, Saurabh. So which means, let's say I have a renal cell carcinoma. RCC is renal cell carcinoma. So what will happen is, it'll grow from here, it'll grow here, it'll grow here, grow here. It'll grow. It's like a snake. It keeps on growing. Can even grow till the heart. It grows inside vessel, does not spread via the vessel. That is intravascular growth. Some of your hospitals, especially older hospitals, might have definitely specimens of these where a tumor has invaded the vein and gone up. That's intravascular growth, right? Can you quickly go through everything? Okay. Mets, we know what is metastasis. Most important word is physically discontinuous. We have lymphatic, hematogenous, exceptions for hematogenous, which can sarcomas can go lymphatics. Please don't forget about sentinel lymph node. Talk about seeding of body cavities, special. Krukenberg is special, drop is special, and your intravascular growth is special. Clear? Done? Okay. Can you go to steps of metastasis? Possible? Yes? Okay. Just give me a second, guys. Done? Fine. So now we'll go to steps of metastasis. We know what is metastasis, what are the types of metastasis. Now, how does it spread? Both steps of metastasis and the types of metastasis, there's a very high likely chance both can be combined for a long answer. They give you a random question on patient with breast cancer, had a sentinel lymph node biopsy, and because of this biopsy, we know that it is positive. Tell me what is this process, tell me the roots of this spread, and also talk about the steps of how it goes to axillary lymph node, right? This can definitely be clubbed into a long answer, right? Now, there are 6 steps. Loss of E-cadherin, destruction of ECM, epithelial mesenchymal transition, formation of emboli, chemokinexate, formation of metastatic deposit, right? Truth Nation X, love you too. Okay, and this is the image from Robbins. The beauty, na, most of your seniors tell Robbins is not a good book. I want to hold them, everyone, and say you are reading the wrong way. It gives everything in a single image. So if you read the book, if you know the content, revising is easiest only in one book, that is Robbins. Okay, let's go through it one by one. The first step is, cancers are like this, right? It's a cluster of cells. There is no way a 5 centimeter tumor from breast can go and sit in the lymph node. Can't happen. So the 5 centimeter tumor should break down first. So once it becomes cells like this, easy to spread, na? That's the first step. Loss of E-cadherin is the first step of metastasis. What does it do? So this will create a subclone. Cancers are monoclonal. Every cell in the cancer has a same mutation. Few of the cells will have extra mutation. We call it subclone, right? This subclone will detach themselves from main tumor because they have no E-cadherin. When they don't have E-cadherin, it will detach and it will come outside. That's the first step. I have to move a person from one place. First, detach them from their locality, right? Remove them. Then, yes, there's a possibility I can go to a different place, right? That's first. Second is destruction of extracellular matrix or ECM. Okay? Or you can write stroma. Anything is fine. Fine. Now, let's take an example of skin. Assume this is skin and I have a cancer here in the skin, which has invaded the basement membrane and everything. From here, there are few cells which came outside. The cells which had loss of E-cadherin which came outside, right? Do you know where they will be? they'll be actually in dermis, right? They have to be in dermis. Dermis is the stroma because squamous cell carcinoma comes from the epidermis. Now they are stuck in the dermis. Now the goal is I have a tiny vessel here, right? Or a lymphatics. I have to reach here. Only when I reach a lymphatics or a vessel, I can spread. That's my bus. I have to go there, right? For going that, first I have to destroy dermis. Second, I have to move. That's what destruction of ECM means, right? How do I destroy dermis? This happens with the help of tumor infiltrating macrophages. Remember your, what is the name? Wound healing. In wound healing, we talked about remodeling, right? Remodeling is nothing but destroying collagen, making collagen again. Destroying collagen, making collagen again, right? So this tumor infiltrating macrophages secretes, I'm sure you'll remember this guy, MMPs. MMPs are matrix metalloproteinases. Collagenase, gelatinase, everything, right? This MMP will destroy the stroma because the job of MMP is to destroy the stroma, right? So once the MMP is there, what will happen here is, okay, let me make a path for you to go. So MMPs will say, I've made a path to your blood vessel. Please walk. But the problem, it's epithelium. Epithelial cells moves or not? Sorry. Epithelial cell moves or not? They don't move. Who moves? Mesenchymal cell move. Epithelial cells don't move. Mesenchymal cells move. Mesenchymal cells have actin and vimentin. They move, right? Epithelial cells don't move. That's my third transition, right? Third step is, we call it epithelial. EMT stands for epithelial mesenchymal transition. So now I have got the way, but unfortunately it's a squamous cell carcinoma. It's an epithelium. With the help of two genes, twist and snail. These are two genes which converts this epithelium to every mesenchyme, we call it a spindle-shaped cell, right? To a mesenchyme. So once they become a mesenchyme, they automatically acquire actin and myosin. With the help of actin, they will move towards, my goal is simple, a lymphatic or a vessel. Got it? Clear? They'll move towards a lymphatic or they'll move towards a blood vessel. That's how it goes. The moment it reaches a blood vessel, what they'll do? They'll enter the blood vessel, right? So inside a vessel, this happens inside vessel or lymphatics. Inside the vessel, they're not alone. There are multiple logics for it, but the reason is tumors are extremely intelligent. That's the reason. So inside a vessel, what they do is, they don't stay alone. This is a tumor cell, right? What they do is, they cover themselves with WBCs. They cover themselves with platelet. They cover themselves with fibrin. Right? This is what they do. They don't stay alone. I'll tell you why they don't stay alone. So what happens is, inside the vessel, they form a tumor emboli. There are two very important reasons for tumor emboli. Tumor emboli has the tumor cells in the center and surrounded by WBCs. Okay, surrounded by platelets, surrounded by fibrin. Okay, why? Why is a question which takes us to the next level. Normally, just answer this question. I have a squamous cell into my blood circulation, into my blood vessels. Do you think my WBCs will keep quiet or they'll try to destroy? They'll definitely try to destroy. But now, the tumor emboli, the outside surface of tumor emboli is made by WBCs, platelets and fibrin. It's looking like a self-antigen or a foreign. self-antigen, right? So now this tumor emboli has two reasons. One, they can escape WBCs in circulation. Otherwise, they'll be killed next second. If they don't form an emboli, the next second they will be killed. One, they can escape. The second, what they do is, now if you look, the outer surfaces, WBCs. Can WBCs move to chemokine signals? They do. With the help of these WBCs, on the outer side, happens the next step, chemokine mediated exit, because WBC is the only one which will respond to chemokine, nothing else, right? So with the help of chemokines, there are a few chemokines called as CD44 which helps them exit into lymph node. There are a few chemokines. We have CXCR4, CXCR5, CCR7. These are few chemokines which are involved in breast metastasis. They go there, right? So from here, it moves outside. It moves outside and they go there to the metastatic deposit. If it has to go to the lung, gets outside in the lung. If it has to go to the axial lymph node, gets outside there, right? There, what they form is, so they go outside and the first step is they have reverse of MET. Reverse of EMT, that's MET. Because it is an epithelial cell, na? Now it has to become mesenchymal again, right? Becomes mesenchymal. Once they become mesenchymal, automatically they go to the next one, right? Next, it goes in, deposits in the place, it goes, divides, and it will destroy the native tissue, right? Okay. Hi, Ira. Lyrics, which one? Which one you want me to explain? Can you tell me the step number? I'll tell the step number. I'll go again once again completely also. I'll tell the step number. I'll explain in detail. Fine. So goes, destroys. Now, there are few things which are common for every metastatic deposit throughout the body. First thing, in lungs, in liver, in heart, in CNS. In these organs, Mets are much more common than primary tumors. Okay, sure, lyrics, I'll do it. So what do I mean by this is, in CNS, metastasis to CNS is much more common than meningioma, much more common than glioma. That's one. Second, every Metsna has few common features. It will be well defined. Mostly cancers are ill defined. Mets are always well defined, right? Mets are always in the periphery of the organ. Mets are always multiple, they are never single. Mets always will have central necrosis. So if you see any image in the lung or liver, multiple rounded deposit with central necrosis, we call it metastasis. First diagnosis metastasis can be primary also. Okay, that's unique for every metastasis, right? I'll tell you what is step 4. Okay, I will go with the image, I'll explain, then I'll come to the theory part as well, fine? Now, this cluster is a primary tumor, okay? Transformed cell is the mutated one. So what happens here? The mutation happens in this, which is your, let's assume, loss of E cadron. Because of that, everything is separate, right? This is my stroma. This entire part is the stroma, or the dermis is in our example. So this cell secretes MMPs to destroy the dermis, right? Became a mesenchymal cell. To move, EMT should happen, only then it can move. The moment it moves, it can enter into the blood vessel. Here it's my vessel. The moment it enters the vessel, I have this guy. This guy can destroy the cell because lymphocytes has the capacity to destroy the tumor emboli. They're tumor cells, they are foreign, right? How do I escape them? What I do is, the tumor cells are so smart, they cover them with platelets, right? They cover them with more WBCs, lymphocytes, neutrophils, lymphocytes, neutrophils, lymphocytes, neutrophils. So now, for a host lymphocyte to look at this, looks like a lymphocyte, neutrophil, and platelet, not a tumor, because tumor is in the center. Escapes my immune system, and with the help of chemokine, who tells them, exit here is chemokines. With the help of chemokines, because chemokines is going to attract the WBC. It will pull the WBC outside, piggybacking, tumor also goes outside. Then it goes to a place and it has MET and it deposits. Clear? Robbins has an image which also is marked as well. Fine. Clear, lyrics? That's what happens here. Fine. These are the classical steps of metastasis. Yes, no, maybe. Done? Perfect. Right? So we know about the steps of metastasis as well. Right? So we know about steps of metastasis. We know about metastasis. Saw about proto-oncogene. We saw about tumor suppressor gene. We saw about evasion of immune response. Right? So I'm stopping this lecture here. This is neoplasia part 1. I'll have part 2 as well, where I'll be covering these carcinogens, an important 5 mark. Possibly, if I can compile everything, can be an essay as well. We'll have to look into all the types of carcinogenesis. We'll look into the diagnosis of cancer. Very important, not just clinical. We look at paraneoplastic, we look at tumor markers, we look at markers, we look at rest of it, right? So next class I'll tell you, I'll put you in the group. If you're not in the group, ping me, I'll add you to the group, right? The phone number is 7760157195, right? I'll add you to the group. I'll put there. When you have the part 2, we'll complete neoplasia in 2 parts. I think that should be enough for you as a last minute resource. This will not replace learning. This will help you to supplement your learning part. Fine. Okay. Thank you guys. Thank you for your patient listening. Spending 1.5 hours immediately after your class is exhaustive. I can understand, but amazing work. Fine. Thank you guys. See you soon in the next class. Till then, bye-bye.